So that was we did a post-hoc analysis looking at conditioning in intensity. Patients on that trial received either myeloablative or a reduced intensity conditioning. 60% received myeloablative, 40% reduced. And there is a general thought in the field of transplant that myeloablation is always better than reduced intensity conditioning if a patient can tolerate it. However, that's again lumping all of AML into one category, and in fact it isn't one disease. So when we looked at this by mutation subtypes, NPM1 again is a unique category of AML. The NPM1 mutations drive expression of FLT3 and tend to generate a FLT3 addicted clone. If you wish to decide whether or not to give myeloablation, you also need to take into account if the patient needs to have post-transplant maintenance with a FLT3 inhibitor. If they get myeloablation, it's harder to do because the patient is often sicker and can't start the drug sooner. And in fact, when we looked at this post-hoc analysis, patients with an NPM1 mutation didn't benefit at all from myeloablation, irrespective of young or old. They really needed the FLT3 inhibitor. So the post-hoc analysis suggests that for NPM1-mutated FLT3 ITD-AML, you should not be using myeloablation at all. But then that gets into the next component of the argument. Myeloablation is supposed to eliminate MRD. But we had a direct way to test this. We had MRD measurements by this FLT3 MRD assay pre and post-transplant, immediately before getting conditioning, immediately after. And so we asked the simple question, well, if myeloablative conditioning works so well to eradicate MRD, let's compare MRD pre and post conditioning. We have myeloablative and non-myeloablative. And there was not a whit of difference between the two. Myeloablative conditioning did not eradicate MRD any better than reduced intensity conditioning. Again, turning that concept on its head. No, you're wrong. Myeloablative conditioning may be a good idea for some, but not specifically for the FLT3 NPM1 mutated AML.